This morning's speaker needs no introduction. We have Dr. Barroilhet joining us this morning to give us a very excellent grand rounds. She's an associate professor in the GYN oncology department, as we all know, recently served as our interim chair, is a R01 funded researcher, has received multiple awards for teaching and mentorship, and we're lucky to have her speak with us this morning.
Good morning. Can I get a thumbs up from someone online that this is working the way it's supposed to? Silence. Melody, can you see signs of life from the online community? We'll just hope for the best. Okay.
It looks great. Sounds great.
Amazing. Thank you for the feedback. You just never know what's going on out there. So the code, if anyone's on the phone, is WOGMED. And let's get going. So I have been here. I don't think everyone knows this. I've been here a decade now. I just passed my 10-year mark as a faculty member at the University of Wisconsin. It went very quickly. But the reason I say this is in that 10 years, as you can imagine, I've given grand rounds a number of times. And I've talked about ovarian cancer. I've talked about risk reduction surgeries. I've talked about restrictive blood transfusion protocols. I've talked about the work in my lab related to cellular energy metabolism. If you had told me a year ago that I would be standing in front of this group talking about abortion and what has happened in our state after abortion became illegal, I would have told you all of those things were impossible. And if you'd added on to that I'd been, in an interim leadership role in the department tasked with trying to figure this out among many other humans, I would have said, well, there's no way I would have ever said yes to that job. That just sounds crazy. So it is amazing where life takes you. And I'll mention my conflicts. They aren't particularly relevant to this talk and what we're going to work on today. So many of you in this room, and I know the online community joining us is probably more diverse, but standing before me is sitting before me are a lot of clinicians, administrators, people who have been working so closely with the department through this transitional time. But there are many others online, I suspect, joining who haven't been in the weeds quite as much. So we're going to review the current law surrounding abortion care in Wisconsin, outline clinical situations where abortion remains legal, and discuss access to abortions for patients with chronic health conditions. I'm using some cancer examples given my own clinical practice. So I know that I use the word woman in a way that maybe doesn't make sense to everybody. What I meant to describe when I say women's health or talk about access to abortion for women is that we understand that terminology is used a lot, but it doesn't mean that only cis, straight, non-trans patients get pregnant. There are a lot of non-binary or people with uteruses who don't identify as women. And I want to honor that, understanding that I'm going to use the word woman to define someone who's capable of becoming pregnant in this talk. I also want to recognize that I am fully aware, as Ahmed just said, truth-telling. I wear my heart on my sleeve. And I think anyone who's talked to me for 5 minutes understands how I feel about abortion access. I know not everyone feels the same way I do. And that is there's a lot of space for different moralities surrounding this really complicated issue. And so my hope in this talk is to really lay out some objective facts, some research being done just where we are. But I also know myself well enough that I'm completely unable to do this without inflicting my own bias and emotion inadvertently. So I'm just going to acknowledge that, and I'll work hard to keep it to a minimum. But also it's different when you're talking to a crowd like this. I've given this talk in so many version of this talk in so many different settings. And this is the home game for me, right? You are my people. So you already know me and how I feel. And it's going to be pretty obvious some of my concerns about the health and safety of the women in our state and the current landscape. So this is what we know about abortion before the Dobbs decision in June of this year. About 18% of pregnancies in 2017 ended in abortion, and it does exclude spontaneous abortion or miscarriage. 75% of abortion patients in 2018 were poor or low income. So that means they either were below the federal poverty line or less than double the federal poverty line. At 2018 abortion rates, about 1 in 4 women will have an abortion by age 45. This is an incredibly common procedure. But it's declining. So all this data comes from guttmacher.org, and that's a very good, if you're looking for data about abortion, it's one of the most accurate websites available, and they actually intend to have their data shared for this purpose. They really want people to understand facts, and they have a lot of good graphical representations of data. Of course, it's always a few years old because that's how life works. But what you see here, and the blue and the yellow are meant to demarcate pre-row and post-row. So the below 1973 levels, we're actually there now. We're there prior to in the last 10 years. So really after 2013, we saw a market decline. So basically abortion levels were actually as low as when abortion was illegal. And you can see the peak here in this chart was in the early 80s. Most of you are familiar with the incredible work by Jenny Higgins and her team in the Collaborative for Reproductive Equity, so CORE. So Jenny and her group did a really comprehensive survey, many of you took it, of physicians at the University of Wisconsin School of Medicine and Public Health. It was distributed incredibly widely. I think it came with a $5 bill. I would have filled it out for free, but 900 physicians responded, which is a pretty fantastic. I don't remember the percentage response rate, but quite high. And what we learned from this survey was a survey all about attitudes towards abortion, is that there is actually incredibly high support for abortion being legal and accessible among physicians at our medical school. There's pretty low support for abortion restrictions, and 9 out of 10, this was distributed several years ago, so well before Dobbs, 9 out of 10 felt that women's health in Wisconsin would get worse if Roe were overturned. And these findings were actually quite consistent across medical specialties. It wasn't just our department who felt this. It wasn't just women who felt this. It really was very evenly distributed. And this is just another way of showing the same data. So we really have support abortion access somewhat or a lot in about 80% of physicians. About 13% oppose somewhat and 3% oppose a little. Some people were neutral, very few were. Most people felt pretty strongly in favor of abortion access and unrestricted. So that means without the waiting period, without all the layers and loopholes that we deal with. So this is all kind of how we got to where we are legally. So before the 1848 statute or 49 statute. So when Wisconsin gained statehood in 1848, there was no law anywhere that criminalized abortion. The earliest abortion statutes were enacted in 1849, and that's the one that's 940-04, which is the one we're currently dealing with. And we'll talk more about that one specifically. The earliest abortion law in our state applied only to a quick child. As you know, that's an antiquated way of describing a woman who's able to feel the fetus move in her body. So a pretty challenging definition, hard to pin down via gestational age, but probably the best they had in the mid 1800s. It did expand to pre-quickened pregnancies, so essentially all pregnancies in 1858. And it really was in 1955 where the current statute kind of came into being, and we'll talk more about that. So there are other layers of abortion law, and this has been really interesting for me to understand. I know that our abortion providers in the department live these realities every day, but as a GYN oncologist, I don't. Prior to Dobbs and prior to being in the interim leadership role, I acknowledge that my understanding of abortion law was pretty rudimentary, and I understood abortion to be legal in our state, and I understood that there were restrictions that were challenging, but I didn't really unpack all the layers and all the hoops that had been put in place to make abortion incredibly challenging, not just for patients, but for clinicians. So the Abortion Prevention and Family Responsibility Act, which was initiated in 1985, establishes that a pregnant person who obtains an abortion may not be prosecuted. So that's really important and remains important today. And it prohibits the performance of abortions post-viability, except to preserve the life or health of the woman. This is just a whole bunch of layers of laws that have been placed since 1985, most of them in the 80s and 90s. So informed consent requirements, annual reporting requirements, and this is well beyond the informed consent that we always do with our patients before any procedure. The residents, our abortion providers know these to be lengthy, time-consuming, and frankly, way more scary than they need to be to describe one of the safest procedures done in inpatient or outpatient settings. There's special consenting requirements for minors who obtain abortion, a 24-hour waiting period in non-emergent situations, additional reporting requirements, and a ban on partial birth abortion, which was enacted in 1997. So what makes this very complicated is all of these things are still true, right? When Dobbs was overturned, we go back to the 1849 statute, and then all this stuff still is layered on top of it. And that took me quite some time to figure out. And this is why lawyers are important. There's actually a number of reasons, it turns out. But watching really experienced legal experts walk through all these layers of abortion restrictions and legislation is quite impressive. And this isn't all of them. This is just state laws. There's civil laws that are also pieces interwoven here, but I'll spare you some of those details. So here we are. Now we're June 24th. I will never forget that day. So when the Dobbs decision was released, we became immediately aware that the US Constitution does not confer a right to abortion. That was the Supreme Court's decision, and that the authority to regulate abortion is returned to the states. So we knew, and because of the Dobbs leak in May, we had a sense that this was coming, and there was some opportunity to prepare. I would say that is maybe the only good thing that happened in that period of time is the warning. And I don't know if anyone knows who leaked that, but I would love to send them a thank you card. I think it did make a truly terrible situation slightly more tenable. So we had some time to really think about what it was going to look like in our state, and really take some time to form alliances throughout the state. So we could think about how the law was going to be interpreted in a manner that, to the best of our ability, kept our physicians safe and also kept our patients safe. Even in this terrible landscape of very restricted access. And that, I think, was probably important, because I think once we got a number of institutions across the state to say, yes, this is how our legal team's interpreting it. Yes, these are some of the conditions we think are important to make sure that a life-saving abortion is available for. And yes, we think we're all safer if we're practicing medicine similarly. So I do think one of the things that is helpful in this terrible landscape is that we know that what's happening here is very similar to what's happening at MCW, is very similar to what's happening at Gunderson. And that does give us some strength and ability to defend our actions when we are performing life-saving abortions. So here we are. I think most of us can recite the statute in our sleep by this point. I know I can, but this is a reminder that any person other than the mother who intentionally destroys the life of an unborn child is guilty of a Class H felony. So that's a big fine and potentially time in prison. It does not apply to a therapeutic abortion that is performed by a physician and is necessary or is advised by two other physicians as necessary to save the life of the mother. And they do use some descriptors about maternity hospitals, which are fairly antiquated and don't really apply to how maternity care is currently delivered. So in this section, an unborn child means a human being from the time of conception until it is born alive. Conception, as you know, is not really a term used in medical textbooks or taught in OBGYN residencies. ACOG did something, I think, proactive and smart and made it clear that conception begins at implantation, not prior. Wisconsin does not have a trigger ban. So many states did. And trigger bans mean that there was legislation specifically put in place so that when Roe was overturned, a new statute written in the current era would come into place. Wisconsin also does not have a law that criminally penalizes a pregnant person for obtaining or performing her own abortion under any circumstances. When I think about things that are vulnerable in the future, I think about that. But right now, the physicians shoulder the burden of the legal consequences. Silver lining, that doesn't seem like quite the right word here or phrase, but it is important that our patients understand that, because I think a very dangerous place to live is one where patients who've had abortions are scared to get post-abortion care when they need it, or don't want to acknowledge it, because We need to know what's happening to our patients. We need to have data. We need to do research. We need to understand the post-Dobbs experience and what really is happening. If no one feels comfortable sharing they've had an abortion because they're scared of criminal charges, we're never going to really understand the breadth and depth of what has been harmed. There's also no personhood amendment in our state, and there's no law restricting travel. This is also, I think, potentially vulnerable, but right now there is no law restricting travel for the purpose of obtaining an abortion. It's also important to remember that physicians can talk to patients about abortion. Right now, there's nothing that limits what we're able to share with our patients. We can talk to them about how to obtain a safe or legal abortion in Illinois, in Minnesota. Absolutely fine. I think that is vulnerable, but the case today is we can do it. So the complications of self-managed abortion, medical abortions, abortions received out of state, of course they can be treated. And I've spent a lot of time educating our ER physicians, both at Meriter and at UW, that there's nothing special that needs to happen to these patients. You take care of them as you always had. There's no special documentation. There's no HIPAA violations. You don't have to report anything. Social work doesn't have to see the patient unless there's other indications. And the other piece of that that's really important is what our pharmacists are doing. So we've worked a lot in the UW health system to make sure misoprostol remains available at all the pharmacies where it used to be. Mifepristone comes with a bunch of very limited prescribing opportunities. So of course, it's not going to be widely distributed at pharmacies, even if it is being used for appropriate miscarriage care. But we have heard anecdotally that community pharmacies have been a little bit more difficult, and it seems varied. It doesn't seem like there's any one pharmacy that's been a problem. It doesn't seem like Dane County's been a problem, but I'm hearing stories from other parts of the state where pharmacists are not filling prescriptions for medications that could be used for a self-managed abortion. Now you have to remember, you have to be intentionally destroying the life of the unborn child. It's the intent that matters. There's no expectation in the law that a pharmacist figures out what the medication is being used for. There's no expectation in the law that they are the gatekeepers. So I think something we can do to be helpful is clearly write on those prescriptions for miscarriage. I hate to add even one more step in our already crazy lives, but the pharmacist is then completely removed from the decision, right? They understand why the medication is being prescribed and really have no basis for not prescribing it. I'm also talking to the Wisconsin Pharmacy Society about this topic. And I would say that they have tried very hard to educate, but there's hundreds and hundreds of pharmacists throughout the state of Wisconsin. So it's really difficult to have the scope and reach that you need to make sure everyone understands the legal implications. Contraception, everyone knows, is completely legal. All current contraceptive services offered continue at UW Health. Plan B is available. IUDs do not cause abortion. And there's no obligation, I wrote this, that pharmacists act as gatekeepers. I also want to remind, I didn't put this is one of the laws related to pregnancy and abortion law in Wisconsin. You actually must offer Plan B to a patient who's experienced rape or incest. It's the law. So right now, and that law is real and active right now. So if you are in an emergency room and are seeing a patient who has experienced sexual assault and you are not offering them emergency contraception, you are in violation of the law. So that's been an important point to remind our emergency room colleagues and other patients, other providers seeing patients in that setting. So we know that IVF is legal in our state, embryo storage, embryo destruction. Those pieces right now stay unchanged because conception and fertilization are two different things. And none of the statutes in place talk about fertilization specifically. There's no changes in care for ectopic pregnancies. And that was some of our early mishaps, was ER physicians concerned about prescribing methotrexate and wanting to get additional physicians at testing that it was a life-saving procedure. Again, how the law is written is that for it to be an abortion, the situation has to result in a live-born child. That's not what an ectopic pregnancy is or does. It cannot result in a live-born child. It is not an abortion. So this care has been unchanged. And I think protecting ourselves is really as simple as documenting this pregnancy is not in the uterus and cannot survive. This is a medical emergency. It's the same things we would have said previously. So What we can do still is refer, and I have spent a lot of time trying to understand what is happening to patients who are being referred. And what I'm hearing is it's going okay, that we have some really amazing resources in place, including Planned Parenthood of Wisconsin, who remains very committed to helping patients get access. We have our own family planning coordinator, and I'll talk about Cassidy and her marvelousness in a little bit. So there are ways that we can really help patients access care elsewhere. Illinois and Minnesota, most notably given our geography, but the wait times are certainly longer. And it has been more challenging to get in, and patients who would have easily had abortions well within the first trimester are now having abortions an average of 2 to 3 weeks later. Again, this is all anecdotal. This data needs to be collected at a very high level and analyzed. I'm giving you the scope of what's being told to me one-on-one. We have to recognize that's not science, but it makes sense, right? This is what one would expect to happen. We know there's thousands of abortions that were previously being performed in Wisconsin, and patients with resources are going to still try and access those services. We know there's no abortion services at Swedish American Hospital. There's two questions I get asked all the time when I give this talk to other departments. Is one, why don't we just do this at Swedes? And I just forgot the other one. I'll come to me later. But it's because there's actually never been abortion services there. And actually, it's a very difficult thing to start a new abortion program in a hospital. And I do think this is open to ongoing discussion, but it's not a switch that can be flipped. And you have to have staff, nursing, MAs. It can't just be physicians who are willing to go there and perform the abortions. You need all the infrastructure and support services and security that comes with abortion by necessity. And that you cannot just say, oh, we're just going to quickly pivot. And because UW Health owns this hospital, we can suddenly just do anything we were doing previously. We can just move it. It's much more complicated than that. Denny Christensen's in the room, one of my favorite humans, who along with others is opening an abortion clinic in Rockford. The Rockford Family Planning Foundation should open 2023 early. Yes, he's nodding. Yes. So that is huge. And I think it's important to recognize that's huge for the patients in Rockford. Access there has been really challenging. So while I am so grateful because this is an opportunity for our trainees, this is an opportunity for our faculty, this is an opportunity to have closer access for the women of Wisconsin, Rockford absolutely has need. And the mayor of Rockford has been very supportive of this effort. There's several members of the city council who've been very supportive. And I also just want to acknowledge Lily in the space, who's been amazing. Just want to say that too, because this is one of the first things that was set in motion almost immediately after the Dobbs decision was reached. And I'm glad that so much progress has been made. So a recent publication, literally this month, talks about what the effects of recent abortion legislation have done to maternal outcomes in Texas. This is in the Great Journal this month. Anjali Nambiar is the lead author. And the title is Maternal Morbidity and Fetal Outcomes Among Pregnant Women at 20 Weeks Gestation or Less with Complications in 2 Texas Hospitals After Legislation on Abortion. So it's 2 hospitals in Dallas, the University Hospital and Parkland Hospital. Anyone familiar with those programs or hospitals know that's a very high volume obstetrical space. So they're seeing a lot of pregnant patients with a lot of different complications. So to be included in the study, you need to be less than 22 weeks gestation. They were trying to get out of that peri-viable space. That you had to have a medical indication for delivery. And while they did not make an exhaustive checklist, examples were pre-viable premature rupture of membranes, severe preeclampsia, vaginal bleeding or hemorrhage. And the fetus had to have cardiac motion. So we had to be in this space where the concept of abortion was being applied. So there was only 28 patients who met inclusion criteria. The mean days between presentation and delivery was just over 9 days. Maternal morbidity occurred in 12 of the 28 patients, 42%, and 9 of those patients, so 32%, required ICU admission, D&C, or readmission. So had an additional interaction with the medical system that they would not have needed to have had. You got me. One patient did require a hysterectomy. That was a patient with abnormal placentation. There were no maternal deaths, and for that I am grateful, but it doesn't, on the other hand, it doesn't it makes this more complicated to interpret when you're talking about life-saving abortion, right? We know bad things happen to these women. We know that their care could have been better. Does this help someone in the state of Wisconsin who's trying to figure out if an abortion is life-saving? It's too soon to say. But I will say this. So what they did is they compared what would have happened to these women if they had access to immediate interventions, and they didn't have to wait for the fetal heartbeat to go away. If they could just perform the termination or induce labor at the time of presentation without going through all the steps that Texas requires to terminate a pregnancy. So expectant management resulted in 57% of patients having serious maternal morbidity, compared with 33% who elected immediate pregnancy interruption under similar clinical circumstances. So they did some age matching, gestational age matching, reported in states without such legislation. So women are being harmed. We know this. We know this intuitively. We know this from the early data coming out. And there will be another study like this, and there will be maternal deaths in this study. That is just the reality. And it's hard to see that. I want to talk briefly about medical abortion, just to remind you that that's really common. So in 2018, about half of all abortions performed in the United States were performed using medication. And in Wisconsin, clinicians who provide medical abortion medications, must be physically present with the patient. And that's legislation that existed before Dobbs. So while there are definitely ways to get abortion medication mailed to people in the state of Wisconsin, it is in violation of the law. So I just remind you of that for knowledge sake. Aid Access is probably the most famous organization that does this work, and they do it by sending medication via a pharmacy in India, and the physician prescribing it is in another country and very unlikely to be extradited. So it works, but there are some legal consequences to it, and that should just be noted for anyone who's recommending that service to others. All of you have seen this. So on UConnect, there's a list of helpful resources. And I just want to remind folks, we are really making an effort to keep that website updated. So as people make suggestions to the content, we try and improve it. There are dot phrases that are available both in English and Spanish that you can provide information to patients about reproductive options. There are links to websites that can be helpful, including Planned Parenthood of Wisconsin, Pregnancy Options, US Abortion Clinic Locator, and others. And it does have a link to our own early pregnancy assessment clinic at 20 South Park. So there's a number of resources that are available in the intranet. If you're on Meritor's website, you can actually link to it directly. So for anyone here who does not have access to UW Health or routinely log on there, Meritor has provided parallel information. And we also have a frequently asked questions area. So if you are getting questions for people in the community, even if you know the answer to them, or people, ER physicians are asking you questions, residents from other programs are asking you questions, even if you don't know the answer, maybe make the assumption that lots of people don't know the answer, let me know about it. And we can put it up in our free FAQ section, trying to disseminate this information in real time. There's a number of videos of me speaking that are pretty humiliating, but it also goes through if anyone wants more information about some of this type, the legal consequences, the realities we're in, patient education. It is all there, and it will be there for the duration. So we've talked about this. When can we do abortions? When can we say an abortion is necessary to save the life of a pregnant patient? This is a list of examples, not an inclusive list. And all of you, I believe, in this room have seen what our clinical consensus guidelines. Those are also available on UConnect. They're on SharePoint. Laura Jacques has made a number of efforts to have them distributed and the scope be far and wide. And those are also the same guidelines that are being used at our peer institutions. So they are worth looking at. And the first thing the guidelines said is this is not meant to be an exhaustive list. And it's not, right? We know this about practicing medicine. We know this from Jesse's M&M this morning, right? Things that you get surprised clinically all the time when you see something that you've never seen before. This happens to us in obstetrics constantly. And it happens in all fields of medicine. So it's important not to feel boxed in by the guidelines, but just look at them as what they are, examples of framework. And of course, in those guidelines, it talks about early pregnancy loss, and ectopic pregnancy is not even being part of the conversation, just business as usual. And then it goes through all of these indications and what that might look like. And it does cite the ACOG recommendations that patients with asymptomatic PPROM, pre-viable, even if they're not infected, be offered termination or induction at time of diagnosis. So that is all there, and that is the standard being practiced throughout the state. That does not mean every physician's beholden to do those things. Of course not. The solution to this problem is not for me or anyone to tell physicians how to practice medicine. That's exactly what I'm trying to avoid, is I don't think anyone should be telling other people how to care for the patient in front of them, other than the physician and the patient together. That's who should be making those decisions. So I acknowledge that there's a lot of room for interpretation and a lot of fear about facing a criminal charge. But I also want everyone to understand how these consensus guidelines were created and the true wider scope of them being enacted throughout the state. So what about the health of the patient? This is not where we are now, but these are where the ethical quandaries that are starting to come up, because we have created and been successful in doing abortions when needed to save the life of the patient. And I think it's not been easy, but it's gone as well as it could. And that's largely thanks to tremendous efforts for many of the members of the ACOG and MFM divisions. Carla Griffin has been outstanding. And the Meritor support staff in general have been unbelievably helpful to make sure the patients that need life-saving care are getting it. But now we're trying to better define life-saving. And this is starting to come up in my work, in cancer work. And I gave a version of this grand rounds at the Cancer Center a few weeks ago. And we spent a lot of time talking about the intersection. We know the pregnant population in Wisconsin, just like the rest of the United States, is getting a little bit older. And we know that there's a lot of bad things that happen to people in their 30s and in their 40s. That's when a lot of medical conditions, serious medical conditions, tend to present. So this Venn diagram has some very real overlap. It's not just pregnancy-related bad things that can happen. It's the other things that happen in life that then intersect with a pregnancy. So let's talk about cancer. And I have listed here the most common cancers that occur in reproductive age women. Many of you in this room have taken care of pregnant women with these conditions: breast cancer, melanoma, thyroid cancer, cervical cancer, lymphomas. And we know that we can treat it. There's a few different ways to handle the situation if the patient desires that the pregnancy continue. We know I happen to list breast cancer drugs, since it's the most common situation that patients are in when pregnant. And if they choose to keep their pregnancy, they can get chemotherapy for breast cancer after the first trimester. And you can do things like a mastectomy. You can do a sentinel lymph node dissection. You can do cold knife cone procedures in pregnancy. You can do lymph node dissections if you're early enough in pregnancy. There are cancer-related interventions that don't deviate too far from the standard of care that can be safe in pregnancy. So that's great. If the woman wants to be pregnant, that there are things that we can offer that are safe. Where we start to get stuck is when they don't want to be pregnant. And they have a life-threatening condition. So this has not happened to me recently, but this has happened to me. And this at this hospital, a version of this patient pre-Dobbs. And I'll tell you what we did pre-Dobbs, and I'll tell you what I think we can do today. So a 30-year-old who comes in for their first prenatal visit, part of that visit, of course, is a pelvic exam, and the OB provider does a speculum exam to collect a pap smear and sees a visible lesion at the cervix. It's a couple centimeters big and it looks concerning. It's biopsied and comes back as squamous cell cancer of the cervix. So fortunately, there are things we can do safe in pregnancy to work this up. An MRI, of course, this MRI shows the cancer, but doesn't show the pregnancy. Can't have it all, but you can do MRI safely. And you can do lymph node assessments. You can do laparoscopic lymph node assessments. When the time this is not imaging from an actual patient that I cared for, but the time I was experienced this clinical event, we didn't do sentinel nodes. So it was a full laparoscopic lymph node dissection. But we were able to do that in the early second trimester of pregnancy safely and reasonably well. So we were able to do, again, some of the things you would do under normal circumstances. We're able to feel reasonably certain that this was a 1B2 cervical cancer confined to the cervix. So how do we treat that? Well, usually a radical hysterectomy. You could consider a trachelectomy if the patient was interested in fertility preservation, but that is the standard of care. The other option is radiation, which is clearly not going to be, radiation never works to the abdominal cavity in pregnancy. Not to be super obvious, but that's not going to be a safe option for the patient. So really what you would like to offer the patient in terms of her cancer care in that moment is a radical hysterectomy. And in 2016, when this happened to me, that is what I offered the patient. And we did a radical hysterectomy with the fetus in situ, which was effectively a pregnancy termination. And of course, that was after counseling. Of course, I had to select a specific OR team who was comfortable participating in that work. And it was a big kerfluffle, but we did it. And everyone involved felt that that patient deserves that choice and that option to end their pregnancy and receive the best cancer care simultaneously. Is this life-saving? Well, it's hard to know. Cervical cancer, we see people die from it every day in the country, right? It's more than 4,000 women who die from cervical cancer in the US. So cervical cancer is deadly. All of the GYN oncologists in this room, we have several young patients with metastatic cervical cancer in our practice right now. Can I say, and would it hold up in a court of law, that if without the radical hysterectomy, this patient would die? Probably not, right? She probably would make it through her pregnancy. She probably would still be curable with chemoradiation or maybe even with radical hysterectomy postpartum. How much data do I need to be able to share with a prosecuting lawyer to say that my intention was to save the life of the mother and not to harm the fetus? We are going to be in this situation. It has not happened yet at this hospital. It will happen. And I honestly don't know. I think this is going to be a whole thing with many lawyers, and it's going to be really challenging for the patient. And that's actually what's the hardest to comprehend, is this patient facing a new cancer diagnosis, then being told that her treatment options are confined within a framework of a law from 1849. So there are other things we can do for this patient. Just to be clear, she could get platinum-based chemotherapy. She can't get bevacizumab. But really in our current legal landscape, what we would be doing is deferring definitive treatment until after pregnancy. And that's a pretty tough pill to swallow. I will just acknowledge, I think there are cancer cases with good data saying that termination is actually life-saving. The thing that comes up the most in young patients is acute myeloid leukemia, which isn't super common in reproductive age women. It tends to happen to people kind of bimodally, more common in kiddos. But if it's diagnosed in the first trimester, termination should absolutely be considered, because a delay in systemic chemotherapy, even by a week, there's a chart in this paper, it's terrifying, that shows your survival and your prognosis just plummet. So those are patients where I think we could perform a life-saving abortion and have the data potentially to back us up. But I don't know that everyone would do that. I think we would have that conversation here. I think it still might be faster to send that patient to Illinois and explain the situation, knowing that any physician caring for this patient would do everything they can to do it as quickly as possible. But these are the places where it feels really wrong to not be able to immediately offer an abortion for a life-saving reason. So what happens? What happens when standard medical care like abortion is criminalized? We've already seen, sorry guys, got a tickle. You can read for a second. Thanks. We've already seen delays in care. I don't think our department has experienced this, but there is division among physicians, right? People will feel differently about what meets this definition. Increased emotional distress for patients. These patients are already in terrible situations, many with wanted pregnancies, many with new chronic health issues or newly diagnosed chronic health issues that are going to be very challenging to treat. But really the last one is what I've seen: wasted time and effort in an already taxed system. If I can just put on a really selfish lens, just from my experience during the 6 months I was interim chair, I think of all the things that I wanted to do during that time that I didn't touch. Not that I was going to change the department, but I was just going to have things super awesome for Dr. Hartenbach, right? Just have everything really good. Help Kara in her new role. Just think about things I could have ready for Dr. Hartenbach to take to the next level. I didn't do any of that. I was treading water, trying to figure out how to deal with this. And so were many, many other people. So the dean, Trisha. So our MFM division, our ASOG division, the amount of time I've spent with Greg Bills, that he wishes he did not have to spend with me. It's a lot. And there is a lot of emotional and moral distress associated with this. And this is the piece that I feel in my heart when I'm giving this talk and when I'm thinking about these patients and when I'm thinking about our residents and the future OBGYN residents who are applying now. Also, we know this, that prohibiting abortion does not remove the need for abortion, but instead exacerbates the economic stratification between who can and cannot access care. We already know that driving to Illinois for many people is a big deal. Time off of work. How do they get childcare? Gas is so expensive. That's not even the cost of abortion. And let me tell you, there's very few providers in Illinois who take Wisconsin Medicaid. So even for patients who have abortion services that would be covered by Wisconsin Medicaid, it's not going to happen once they cross the border. It's also important just to acknowledge that Black women are more than 3 times more likely to die from a pregnancy-related condition in our country than white women. And that is a burden that we, the big we, has just placed on them. ACOG says that safe legal abortion is a necessary component of comprehensive healthcare. And we have new ACGME requirements. Most of you have seen these, they were just updated in mid-September. And the long and the short is that residents must be involved in educating patients on the surgical and medical therapeutic methods related to the provision of abortion. They must participate in the management of complications of abortions, and they must have access. Of course, there's always opt-out, but they must have access to clinical experience in the provision of abortions as part of the planned curriculum. And they acknowledge that there's going to be residency programs in jurisdictions where it's illegal, but the program still has to provide the opportunity. That's how important ACGME thinks this is. And that's how strongly they feel about training the next generations of OB-GYNs to be competent in this skill. And that's why we are going to make sure this happens for our residents. It's not just, we were always going to make sure this happened for our residents. It's not because the ACGME told us, but I will tell you, this is helpful to us because 1, it underscores how important this education is. But 2, this is this type of argument that we can make to legislatures saying, listen, we have to be able to do this. We cannot have an OBGYN residency without being able to send our residents to get this training. And you want us to have an OB-GYN residency. We know there's not enough OBGYNs in the state of Wisconsin. And that numbers, I don't think this has been a great, recruitment tool for new faculty and for new OB-GYNs in the state of Wisconsin. So it's something worth considering. I think many of you know that Josh Call, our Attorney General, filed in June a case that requests that I don't really know what a declaratory judgment means, but requests to review the statute currently in place, 940-04, saying it's unenforceable because it's ridiculously vague using antiquated language from 180 years ago. So General Call is one of the plaintiffs along with the DSPS, the Medical Examining Board. And I actually don't remember who the chairperson of MEB is, but a group of people. And the defendants are the Senate President, the Majority Leader, and the Assembly Speaker. So right now, the status of that particular legislation is it's pending a motion to dismiss by the defendants. So the defendants said, we are not the right defendants to be implicated in this. And the plaintiffs lack cognizable interest. I mean, none of this really makes sense, but they're trying to get out of it. Is the short sentence. And I don't know if that's going to work or not, but we will see more and more of this because it actually is unenforceable. It is an impossible law to interpret, and it really does need to be clarified. The fear is that the clarifications could be really detrimental, right? The clarifications could include criminalizing patients or impeding our ability to counsel patients about where to obtain abortions legally and safely. So that's why we're in a little bit of a holding pattern. I just put the hub up here again. I want to remind you that I remain active and able to help in this space. And Tricia Kvitrud and Kelly Wilson are outstanding. Tiffany Rapsch, who's a lawyer at Merida, has also been very, very helpful. So there are legal counsel available to walk you through any situation, middle of the night, weekends. You guys know this, they're on call. And I personally have called all of these people at very strange times to review cases and to make sure I understand what is happening before me and the potential downstream effects. I also mentioned Cassidy, who's an amazing family planning coordinator employed by our department. Her work phone number is listed there, as is her email. She gave me permission to share both of those contacts, and she will help you if you have a patient in need. She will help get them to the right place. So these are our takeaways. This is immediate. Abortions are now banned. Many clinical situations are going to continue to arise. I gave you a preview into some of them I think will be coming down the pike related to cancer, but of course there's going to be patients with chronic kidney disease, patients with pulmonary hypertension, other truly devastating health conditions that are only made worse by pregnancy. And I don't know how we're going to manage those case by case. We'll figure it out. But it is, I think we are now entering the chronic maintenance phase, and I think it's going to be quite lengthy. So we know that legal challenges and accreditation reviews may drive further changes. We know that this election in November is important. I'm not telling you how to vote, but I am telling you to vote. I'm asking you all to vote. I think make a voting plan. The only time in my life I didn't vote was when I was a resident and I got stuck somewhere where I didn't anticipate being stuck. So vote ahead of time if you're on call or you're going to be working late. I have these wonderful lanyards, and there's a QR code on my badge that helps patients register to vote. Melody probably has a stack of them in the back, and if she doesn't, she will, I promise, get you one if you would like one. That is it. Thank you for your attention. Questions, comments, conversation. I have the chat up too, so if anyone online wants to type something in, I can see it.
Just a quick question. Any incidents where the patient is expressing suicidal ideation and whether or not that would be considered risk of life?
Great question. I'm going to repeat it on the off chance our microphone's not as good online. The question from Dr. Espinoza was, how about psychiatric indications? So I think we are in a bit better space than we were in 1849 in terms of our understanding of mental health and life-threatening mental health conditions. There is some case law from the late 1800s where someone did try to say that it was a life-saving abortion was performed related to suicidal tendency, and that was not successful. So unfortunately, there is case law in Wisconsin that is counter to that. So I do think that is a risky space for us to be in. It's also, for me, a lot easier to understand why an obstetrical condition or a cancer condition is life-threatening. It is harder for me to say my psychiatry colleague is telling me this, but I'm the one going to prison if they're wrong or if there's a question. So I think that disconnect between the specialty declaring it life-threatening and the person who's putting themselves in the criminal space is challenging. But I do think, again, I've encouraged our colleagues in psychiatry, if you really feel that's happening, let's talk about it. Let's get our legal team together. Let's talk to the clinicians. Let's see what we can do. Because I think it is those challenges that potentially could lead us to a better place. And right now, to me, the better place I'm dreaming of is exceptions for the life and health of the mother. Even that word would make a tremendous difference in what we're able to offer and would allow space for patients who are suicidal. Ahmed. Oh, let's get you a microphone. Oh, I'm sorry. Was there a question down there? We can do that first. We'll get you though.
Mine's quick.
Yeah.
With all the information available on UConnect, how accessible is that to folks who are not UW Health employed?
Yeah, so it's not if you're not UW Health employed. That's why we put it on Meritor. We also have a box folder for people who are just active on campus and have wisc.edu, but it's not, the intranet cannot be made accessible to like campus at large. It is on Box. Yeah, if anyone in this room is not accessing that information, it does not have it at their fingertips because of they work on campus, they're not part of the UW Health system, let me know because I will make sure that you have what you need available. Ahmed.
Question about the life-threatening indication for termination of pregnancy. Can we as providers recognize that the patients own safety is at danger if she declares so? If a patient comes in and she complains that the pregnancy continues, she will be in danger from her society, ostracized from her community or her partner or her family, is that an indication for us to say this pregnancy will definitely is a life threatening to her?
I am so impressed you actually came up with a situation that I had not previously considered, because I feel like I've considered so many situations, but of course that is a very valid and real one. I think if a patient is telling us that again, that would be an opportunity to review the specifics of that case. But I think it's really difficult. I mean, we still, as a group of really experienced and motivated clinicians to take excellent care of women, are struggling with some of the, ACOG approved or indicated reasons for termination. So the more gray the area gets, I think the more understandable conflict and confusion there will be surrounding it. It's really hard. You're right, though. Those are the exact types of things and unfortunately, the only way to know the answers, right, is for people to start bringing criminal charges up. And I'm not looking to start that. But that is how we're going to learn more about what's acceptable in the space, is we're going to see who's getting prosecuted.
Thank you for that talk, Lisa. And I just want to reflect on the fact that as an abortion provider, for the last 12 years, that all of these cases individually are really rare, but these are all diagnoses and more that I have taken care of people for over the last 12 years. And weird and bizarre things come up all the time, individually rare, but in some very frequently. And it's such a difficult space to navigate when there isn't that exception for health. And if there's anything, that minor changes that I would like to see, it's that we would be able to intervene on behalf of maternal health, because so often you can't prove that they're going to die until they die, but you can show that their health is in danger.
I think that's really well said. Thank you for the comments in the chat. And there was a question that I believe we answered related to mental health. The other thing that really has become so much more clear for me in the last 6 months, I provided abortions in residency and as a fellow, but really haven't routinely since then. So we're, again, more than a decade. So while I consider myself an advocate and an ally in the space, I acknowledge that I'm not in it in that way. And watching what Eliza, what Laura, what Abby do, and the burdens they shoulder, and that becoming so much more clear for me, has been a very important and transformative piece of the last 6 months. And it's given me a lot of opportunities to reflect on the burden that they shoulder. And I'm very grateful to them. Let's end there. Give you a few minutes back. Thank you.